Good evening, Dr. Mark Sawkell, a practicing internist in geriatrician in Novato, and you tonight from my role as Chief Medical Officer of Meritage Medical Network. We're going to for about 20 minutes, the risk adjustment programs that are necessary for us to form well and maintain our patients who are in risk programs, such as the Medicare Advantage programs or WHA for commercial. This is geared towards specialists who don't have many high-value codes, but I think it's important that we all understand what's at stake here if we're going live in this marketplace. Definitions, risk factor, or RAF, which is probably the most important term, basically an estimate of a population or patient's complexity. And this was particularly derived by Medicare looking at 10,000 diagnoses, seeing how much the patients cost over the subsequent years, and assigning a point value. This RAF score is combined with two things. One is the hierarchical condition category, or HCC, and these are these high-value diagnoses to which a point value is ascribed. So not diagnosis is an HCC code, maybe 10%, but if these are not documented when the plan and thus the docs will miss out on the reimbursement. For a certain way of assessing the diagnosis, and this goes for whatever specialty you are, except I guess pathology, what you have to do is identify the diagnosis by code and or name, status of what's going on with the patient, like stable, and what you're going to do. You check in months or refer to pulmonary. Then the payer takes the HCC codes, adds it to demographic risk, and normalizes it to an average score of 1. So the average sickness of a Medicare Advantage in the United States is 1. And then based on that number you get, the payment through the plan is adjusted post facto. That means after you've done the work. Okay. So things vary. County. The dash line is basically the unitary line, so that if your score is, let's say, 1.0 on a review of the record of the patient, and then you do the note, and it's post-reviewed by a coder, it still stays at 1. And if it's 9, it stays at 0.9, and so forth. The sign is what we docs actually do. And you can see it does not line up that well with the unitary line. People in St. Paul, for example, bill at a higher level of the pre-review. They bill intensively. They make more money. People in McAllen, Texas, make a whole lot less money because they are not carefully documenting the work they do. We're assuming that these patients are equally sick in this universe. And what's going throughout the states. The kind of dark teal purple area, which you see in the Northwest and the Rust Belt in Minnesota, any of the places that voted for our president here seem to document with high intensity. They are being 5 to 15% more on the same diagnoses or the same illnesses than the average. The other colors, such as you see most of the Bay Area and Southern California, do not document well. And they're losing maybe 5 or 10% or even more. So there's a disparity for the same sickness of a patient group. The Minnesota docs may be making 25% more. Not sustainable. So why is this important? If you look at that, yes, of course, it's a way of making more money for the work we do, but it also identifies, if you code intensively or accurately, it identifies how sick your population is. It allows the plans to compare one physician group's patients to another. It allows my geriatric practice to be compared to a new family practitioner who sees sinus infections and well people. In a way of comparing the complexity of care that one doctor or group has to provide compared to another, and allows population risk studies. RAF also will identify patients who, based on their high RAF number, may benefit from intensive case or outreach. So essentially, risk defines the price that the plan will be paying us based on what we've documented in that year. And the adjustment comes a year or two later. So it's really kind of hard to figure out what's going on in terms of your books, but you'll see that at Meritage. So this is the opposite of underwriting, where basically based upon the demographics and the occupation, the insurance companies provide certain rates. So with our Meritage patients, 30,000 Meritage patients we've had since 2015, and in this product is scanned with Medicare Advantage. How have we done? Well, we started this program trying to educate doctors in 2015. At one point, our RAF score was about 0.7, again, 30% less than the average of the country. We lost $2.5 million, hit our books 2 years later. On December 16th, we brought the RAF up and broke even. The next year, we think we're actually going to make a few million that we should see in 2019. And in December 2019, we project and we hope, and with hope we will, reach a RAF adjustment of $3 million or more when they decide to pay us. So the name of the game is to look at the cylinder here. The documented risk in our notes is the dark blue. That's what Medicare is going to pay us. Actual risk is what the patient actually experiences. So we narrow that gap. We want any diagnosis that the patient has to be documented once per year properly. So a patient who's got a pretty juicy RAF score. This is Esther, 92, and she's got systolic heart failure, depression, RA, and functional quadriplegia, which is a diagnosis I never made until 3 years ago. It basically means someone's having trouble getting up out of a chair without probably 1 or 2 person assist. And if you do that, she's got a lot of high-value RAF diagnoses, HCC codes, and is old, so she gets a demographic risk factor of 0.8 just for breathing. You add up all the numbers, you normalize to a 1, and her RAF is 2.3. So that's a patient will get about, I don't know, $7,000 each year for taking her if we do it properly. So on documentation, this probably again applies to all of you. We have various ways of documenting that we've learned in medical school, and it's easier for us, and some are more discursive and prosaic, and others are more to the point. What the Medicare auditors want, and therefore by extension, what the auditors want, is a clear identification of a diagnosis, and clearly to the status of the patient if it's an old diagnosis, or how got the diagnosis, or logic if it's a new diagnosis, and your plan. Actually. So, for example, let's go to the next slide here. Let's say aortic atherosclerosis. This is a diagnosis that the radiologists have been helping us with, because they're now putting it at the bottom of their notes. What I do is write abdominal aortic atherosclerosis in my chart. How diagnosis, ultrasound. What am I going to do? Aspirin. That's all I have once per year. It is an existing diagnosis. Then I want to diagnosis and see, is this diagnosis a high value code, or is it something that a high value code would be appropriate? So, for example, does not count as a high value code. Major minor depression does, and most of the patients we treat with medication or have a moderately high depression score have actually major minor depression. So my diagnoses are I refine it to major minor depression. I say, how the patient's doing? Well, he's doing fine. Plan, continue, Prozac. That's all I have to do. Abdominal atherosclerosis, if it's a diagnosis, all right, stable clinically, we'll monitor. So to basically identify in an analytic way each of the diagnosis the patient had, rather than lumping them together and having a discussion later. So depression is something that really spans all fields, but certainly mostly primary care and psych and pediatrics. These that are high value, and they're quite high value because depressed patients cost more money to take care of. And the most common here is F32-0, major depressive disorder, single episode. You make the diagnosis by the fact that someone's on an SSRI like Prozac or Zoloft, or have a certain score based upon your evaluation of them. All it has to be. Alcoholics and people with substance abuse, that's another very high value code. If someone was a drinker and they're in AA or they're not drinking anymore, they still have alcohol dependence uncomplicated. And as documented once in your record, alcohol dependence uncomplicated, hasn't had a drink in 7 years, plan, ordered, listening, go to AA, see your sponsor, whatever. And that's all you have to do. Opioids in that is in that realm as well. So these are some that show up a lot in various specialties. Someone has an ostomy, tracheostomy, gastrostomy, ileostomy, colostomy. Just document it once and put in the record once. And that's something I never did till recently. If someone had an amputated toe, document that once a year, because care will think on January 1st, 2019, that the patient's toe is going back. You advise them otherwise and say, toe still absent, wound clean, plan, monitor. Punctuation, I mentioned, it's not due to stroke, but it's inability due to disability, and that can be orthopedic, dementia, RA, multiple sclerosis, ALS. Document it once a year. And finally, senile is one of the most popular diagnoses. Our cardiologists love it. Old folks with senile purpose seem to cost Medicare more money than patients with stable C, and so it's assigned a RAF value. Two codes that are often missed in the charts that we reviewed. I've gone over most of them. One that I want to highlight for you specialists is if you see a cancer, cancer, but if there are metastasis, like to the lymph node or the liver or the lung or the bone, add as a second diagnosis. That's a very, very high value code. The other one we mostly talked about. So to help you with this, 80 patients have some degree of risk, and the bonus, of which we paid out $2 million last year to you all, is very much dependent upon how well we collect on these risk patients. So for the pair doctors, we have where we identify the possible high-value codes and send a nurse out to the patient's home to evaluate the patient and identify the codes and document them. And for you as a specialist, the first step that we have is this Education WebEx, and I want to thank you for participating. This will get you a point for your bonus incentive, and having done this, you'll be able to get a specialty bonus next year. I think there's a total of 6 points, and this is one. If any of you want a little bit more intensive training, we can send out a trainer, myself or somebody else, to kind of spend half an hour with you and go over some of the codes. And we will do coding guides. If you don't have them, we think we've sent them out, but after this, just contact one of us at Meritage and we'll get them to you. Just for fun, if you're a woman with RA who is wheelchair bound, fibrillation, pacemaker, and a Q9, which is depression score of 10, which is mild major depression. These health and what HCCs are likely. I can go over this too intensively with you, but this lady, if the following aren't documented, will miss out on a lot of reimbursement. So chronic fibrillation, which turns out to be a high-value code. If you have chronic fibrillation, then Medicare assumes or then infers that you have a hypercoagulable state, at least in the atrium, and they'll give you points for that. And a major depressive disorder. She has quadriplegia since she's in a wheelchair, and you notice that's worth 4 times as much as fibrillation. She has purpura most likely based upon the fact that she's so old and is on Xarelto. She has rheumatoid arthritis. She has 6 sinus syndrome. So her total normalized RAF is almost 3, worth you an additional $9,600 to the group. So in summary, we're providing the care. Let's just get appropriately recognized. Being appropriately recognized will allow us to stay in this market. The medical risk market is the only one in our counties that competes with Kaiser. And we'd like to get some of those patients back. We don't have a lot of patients moving into county, but that can do some better business. We have to do better than break even. And then I basically encourage you to utilize the new documentation in whatever practice you're in, or diagnosis, status plan, nice and simple, per problem. That's what you get audited on. And then from a population health level, patients with RAF scores can be automatically eligible for case management. Sometimes you find something when you're reading your chart that you hadn't appreciated before. So this is a bit new, but no worse than all the other things we've been subjected to over the past 2 decades. It's something that doesn't take that much effort. We'll try to help you where we can, and I think it will pay off definitely in terms of being able to maintain the patients and getting reimbursed appropriately. Possibly also there's some data that this improves quality. So the hushed crowd, Rex tried to remain focused. Still, he take one nagging thought. He was an old dog, and this was a new trick. I urge you all to master this new trick, and I thank you for your attention.